Okay, this is Sep Stevens. I'm recording the answers to the Harrison's ID quiz for the Global Health course, Reasoning Without Resources portion. Because there's 126 questions to review, we will just be reviewing the answers very briefly with minimal to no explanation of the answers. If you have further questions and you cannot find it in the Harrison's reading, then please feel free to reach out to us to discuss. Okay, without further ado, let's begin. So, edema with purple bullae, ecchymosis, and cutaneous anesthesia necessitates surgical exploration of deep structures promptly. This is all suggestions of a soft tissue expanding fasciitis. Unexplained fever with pain and tenderness of soft tissue, but without signs of acute skin inflammation, should be managed by C, surgical exploration. The next question, a 55-year-old man presents with 3 days of intensely painful and rapidly spreading area on the lateral side of his right calf. The area is raised, hot, and well demarcated, now about 8 inches diameter. Today, a flaccid bulla began to form on its lower edge. His temperature is 102.6 Fahrenheit, and he looks sick. The most likely diagnosis is an erysipelas. The major giveaways here are the rapid progression and the very well demarcated border, which suggests that this is a very superficial soft tissue infection. How frequently do multiple needle aspirations or punch biopsies of the leading edge of cellulitis yield a positive bacterial culture? The answer is about 20% of the time. The reason for this is because a very low bacterial load can lead to cellulitis. Which bacteria causes impetigo, strep, staph, or both? The answer is both. In this question, place an X next to one or more etiologies of chronic skin ulcers that can be seen in Africa. And the answer is all of them. Mycobacterium leprae, MTB, Mycobacterium ulcerans, skin cancer, Pyoderma gangrenosum, and Kaposi's can all cause chronic skin ulcers. This is your differential when you are assessing someone with a chronic skin ulcer. True false, rheumatic fever is not a complication of skin infection caused by strep pyogenes. The answer is true. You can only get it from pharyngitis. True false, MRSA causes a rapidly spreading diffuse process frequently associated with lymphangitis and fever. That's false. Strep, soft tissue infections can cause lymphangitis and fever more typically, and Staph aureus tends to cause more carbuncles, folliculitis, furuncles, and abscesses that may require drainage. True or false? Patients with necrotizing fasciitis often present with only severe localizing pain and fever without evidence of skin inflammation. This is true. And as we talked about before, this would be, telling you that you might need to consider surgical exploration. Erythematous papules in an HIV patient that mimic Kaposi's is called bacillary angiomatosis and is caused by Bartonella henslei and is treated with doxycycline. Below is a picture of this process. The next question asks you, what might be the history of previously healthy young woman in Uganda who presents with little or no fever, refractory hypotension, extensive peripheral edema and effusions, hemoconcentration, and a markedly elevated white blood cell count? The answer here is attempted self-induced abortion complicated by Clostridia sordellii. True or false, as in cirrhosis, SVP also complicates malignant or cardiac ascites. The answer is false. SVP in cardiac or malignant ascites is on a level of case or small case series reports. True or false, SVP virtually always develops in patients with pre-existing ascites. The answer here is true. True or false, SBP, spontaneous bacterial peritonitis, is an uncommon event occurring in less than 10% of cirrhotic patients. That's true. True or false, SVP is a transidative ascites, not exudative. That's also true. The reason being is that the proteins of the complement cascade are found in peritoneal fluid at lower levels in cirrhotic patients than in patients with ascites from other etiologies. Okay, true or false? In SBP, a single organism is typically isolated and anaerobes are rare. Empiric coverage for anaerobes is not necessary. That's true. So in spontaneous bacterial peritonitis, the therapy should pretty much cover gram-negative aerobic bacilli and gram-positive cocci, so ceftriaxone will do the trick. True or false, about 15 to 20% of patients with one bout of SBP recur within 1 year. The answer here is false. SBP actually has a high rate of occurrence. Up to 70% of patients experience a recurrence within 1 year. So it's generally a rare event in people with cirrhosis, but once you've had it once in the past, you have a very high rate of having it again in the near future. True or false, liver abscess is the most frequent visceral abdominal abscess, accounting for about 50% of such abscesses. The answer here is true. True or false, appendicitis is the most frequent source of liver abscess in rural Africa. True. And the reason that is because the abscess develops via portal or systemic hematogenous spread, biliary disease, or direct trauma. And appendicitis goes untreated in rural sub-Saharan Africa. So people don't get timely surgical intervention or antibiotics, it bursts and then it can spread. About 10 to 20% of patients with liver abscess will have no localizing symptoms or signs. That's false. The number is actually half don't have any localizing symptoms. So fever is the most common presenting sign of liver abscess, and liver abscess could be a source of a fever of unknown origin. True or false, splenic abscess usually has localizing abdominal signs in the left upper quadrant along with fever. That's false. About 50% of patients with splenic abscesses have abdominal pain. The pain is localized to the left upper quadrant in only 1/2 of these cases. So it's important to have a very broad differential diagnosis when thinking about abdominal pain and fever, and not lock yourself into things that perfectly fit what your classic conception of an illness is. The next question, splenic abscesses are rare. Name 3 conditions seen more commonly in Africa that are associated with splenic abscesses. So one condition would be rheumatic heart disease with subsequent bacterial endocarditis. Another one would be typhoid fever leading to splenic abscesses. And then a third, sickle cell disease and salmonella sepsis associated abscess. Okay, the next one gives you a prompt with a vignette. So the vignette says there's a 50-year-old patient who's a heavy drinker of waraji or gin daily, who gets drunk 1 to 2 times per week, presents with ascites and increasing abdominal pain. He's never been hospitalized as an adult and was in fully functional state of health without any history of jaundice or abdominal swelling until 2 weeks ago, when a few hours after returning from working in the fields, feeling fine all day, he developed severe abdominal pain at 7 p.m., which prevented him from joining his friends at the bar that evening. That pain persisted through the night, though eased somewhat, but he couldn't sleep. 3 days later, after the pain, he noticed belly swelling for the first time. The swelling has progressed steadily as his abdominal pain over the past week. Exam reveals ascites with percussion tenderness and rebound and a temperature of 101.6 oral. The lab tells you some different results. So what is your diagnosis? What happened here is this patient has secondary ascites due to a ruptured viscus, probably an ulcer, and you would treat with Ceph, Metro, and surgery. The reason why you can come to this diagnosis is because one, the pain preceded the abdominal swelling by 3 days. The guy has no history of known ascites, as we said, as necessary in cirrhosis. So both of those things tilt you away from spontaneous bacterial peritonitis. And other causes of secondary bacterial peritonitis or would be potentially TB peritonitis, and this is a extremely rapid progression of symptoms for TB peritonitis. So thus, he probably had a ruptured ulcer or similar viscous organ, and then he developed this secondary bacterial peritonitis afterwards. Okay, name 2 diseases that are uncommon in the US but frequent causes of psoas abscesses in Africa and the source of their psoas infections. TB and brucella, and the sources that the patients have vertebral osteo or SI joint arthritis, and then it tracks into the psoas from there. Okay. Check one or more. The increase in incidence of vertebral osteo in the West over the past 2 decades is due to 1, technological detection bias, 2, more comorbidities in aging population, and 3, more urinary catheters placed. All 3 of those are true. The only one that's not true is that it's due to more aggressive organisms. Which 3 etiologies of vertebral osteo are common in Africa but rare in the US? The answer is TB, brucella, and Viridin strep, infectious endocarditis, and RHD associated. Microbial etiologies of acute osteo differ between geographic regions of the world. The answer is false. Acute osteo is due to the same organisms all around the world, which is 40 to 50% staph, 10% strep, and about 20% gram negatives. So if you're treating somewhere empirically, you need to make sure your empiric coverage covers these different organisms. Microbial etiologies of subacute chronic OM differ between geographic regions of the world. The answer here is true. So we just said acute osteomyelitis comes from the same organisms regardless of where you are around the world, but subacute or chronic osteo is different. And in this case, things to think about in sub-Saharan Africa are TB, brucella, and rheumatic heart disease, as mentioned. True or false, only 50 to 70% of patients with acute vertebral osteo manifest fever. 30 to 50% do not. The answer is true. So fever is certainly not going to help you, lack of fever is not going to help you rule out vertebral osteo. So it's important to have a broad illness script in this case. True or false, about 1/3 to 1/2 with acute vertebral osteo have a normal white blood cell count or shift. That's also true. Again, it speaks to the importance of a broad illness script. True or false, ESR is the best test to rule out vertebral osteo. And the answer here is true. Increased ESR have been reported in 98% of cases of vertebral osteo. It's very helpful in excluding vertebral osteo. True or false, treatment of acute osteo in either the vertebra or long bones is 4 to 6 weeks of antibiotics. The answer here is true. True or false, IV treatment phase of acute osteo can be as short as 3 to 5 days and followed by weeks of oral antibiotics. The answer here is also true. That's quite remarkable. True or false, about 10 to 20% of diabetic foot infections harbor underlying osteo, and that's false. It's much higher. It's 20 to 60%. So in a diabetic foot, it's very important to consider osteo. True or false, probe to bone test for diagnosing foot osteo has a positive predictive value of 60 to 70%. And the answer here is false. It's actually more like 90%. So probe to bone test is very good for predicting osteo. True or false, plain X-ray picks up 60% of cases of foot osteo in diabetics. The answer is true. That means it misses 40%. So plain X-ray is not particularly sensitive for picking foot osteo in patients with diabetes. All right, true or false, plain X-ray diagnoses 30% of diabetics with foot pain as having osteo when they don't have it. The answer here is true. So the specificity isn't particularly good either, hovering around 70%, but with a range from 50 to 90%. So there's a lot of false positives. So both false negatives and false positives for diabetic osteo by X-ray. True or false, MRSA and beta-lactam resistant gram negatives are principally an osteomyelitis treatment problem in the West, at present not in the tropics. The answer here is false. MRSA is found in ranges from as low as 5 to as high as 43% in various countries. In India, of diabetic foot infections, 70% of aerobic gram-negative produce broad-spectrum beta-lactamases, and 43% of staph or MRSA. So there's lots of antimicrobial resistance in low-income countries as well. Fill in the blanks. Name at least 2 of 3 major clinical risk factors for antibiotic-resistant foot osteo in diabetics. One is poor glucose control, another is long duration of infection, and the third is how big the ulcer is. Larger ulcers have higher risk of antibiotic resistance. Name 2 risk factors for acquisition of brucellosis. A couple are drinking raw milk, homemade cheeses, owning livestock. Others include occupational exposures like being a butcher, etc. True or false, brucella is endemic throughout the world and as an intracellular infection is particularly common in severe and HIV patients. This is false. So brucella is a chronic intracellular infection. That part is true, but there is no evidence that brucella is increased in either prevalence or severity among people with HIV or with other immunocompromising conditions. Okay, now about brucella serologies. So true or false? Serologies can be used to follow response to therapy and brucellosis. The answer here is false. You can't use serologies to follow. Okay, true or false? Treatment of brucellosis can be with doxycycline plus drugs used in treating TB. The answer here is true, depending on whether the brucella is non-localizing or localizing. You would do rifampin plus doxy or start out with a course of Gent along with rifampin and doxy. And there's some alternatives for kids that include Bactrim, but not a preferred regimen. Okay. With appropriate drug therapy, relapses of brucellosis is rare, less than 5%. And that's actually false. Even if treated appropriately, relapses are common and is at least 5 to 10% in clinical trials and higher to over 20% in more real life non-trial situations and 30% or higher in poorly compliant patients. So there's a significant risk of relapse. True or false? There are 10 to 20 infectious TB bacilli emitted per cough. False. There are over 3,000 bacilli per cough in a patient with pulmonary TB. In general, true or false? In general, patients with HIV and TB are less infectious than patients with TB without HIV co-infection. And the answer here is true. When people have HIV co-infection, they have fewer bacilli. There's a lower load of TB that can actually make them sick. And this lower load also coincides with less cavities than in people without HIV. True or false? One index case of TB on average infects 2 to 3 close contacts. And that's false. One index case of TB can infect up to 20 contacts, an average of 3 to 10 per year. Notice here, the remarkable part is that we talk about spread to contacts over the course of a year, unlike many viral infections where you're talking about spread over a few weeks. So in the short term, TB is not particularly infectious, but the danger is that people can be infectious with TB for such a prolonged period of time that they're ultimately, over a long period of time, is a high risk of spread. And this has major public health implications. Okay. Uh, Next question. True or false? About 10% of infected people will develop active TB in their lifetime. That is true. So 90% of people infected with TB will remain in a non-active or latent state. True or false? The highest incidence of TB is during late adolescence and early adulthood. That's true. So the incidence of TB is highest in late adolescence and early adulthood. True or false? Chronic renal failure, malnutrition, excessive alcohol, and diabetes all confer about the same increase in risk for acquiring active TB. The answer here is false. Chronic renal failure accounts for 10 to 20% of the increase. The others about 2 to 4 times the increase. This is according to the Harrison's textbook reading, as is all the answers here. True or false? Of those with symptomatic active TB, about 15 to 20% become chronic spreaders for over 5 years, neither dying nor remitting. That's true. So almost a quarter are chronic spreaders for over 5 years. True or false? Of those with active TB, half are still alive in 5 years. That's true. This is people that are untreated without treatment. So about 40% are alive at 5 years, and at 1 year, it's about 70%. So again, speaks to the slow, indolent nature of it. True or false? Of those with active TB, about 5% remit spontaneously. False. It's much higher, about a quarter remit spontaneously. And this may be one of the reasons that sanatoriums at the turn of the 20th century seemed like they were effective, because some people would actually be quote unquote cured. True or false? Most primary TB develops in the apices of the lungs where oxygen concentration is the highest. That's false. Primary TB most often develops in the mid-lower lung fields, which receive the most inhaled air. GON complex develops with peripheral, like 1 to 1.5 centimeter infiltrates that caseates in the draining mediastinal hilar lymph node. TB can spread at that stage. When both calcify, the GON complex turns into a Reinke complex. Secondary TB, which is reactivation TB, occurs in the apices where O2 is the highest. So primary TB, mid-lower lung fields. Secondary tends to be in the apices. True or false? During primary infection, TB is disseminated widely throughout the body. That is true. It then is eventually contained by an acquired immune response after 2 to 4 weeks in most cases. If not, you develop miliary TB. And as we mentioned, it awaits further reactivation in 5 to 10% of infected patients and about 10% per year in HIV co-infected patients. So they have a much higher rate of symptomatic TB or active TB. True or false? Fever with TB is usually high, over 102 degrees Fahrenheit, and spiking most days. This is clearly false. Fever is usually low grade and intermittent, often not more than 101, and about 20% or more have no fever detected. So again, important to have a broad illness script. True or false? Scrofula due to TB occurs primarily in the submandibular and anterior lymph nodes, and it's false. It's mostly supraclavicular and posterior cervical lymphadenopathy. True or false? Most patients with scrofula have neither pain nor systemic symptoms, and this is true unless they have coexisting pulmonary TB, which happens in about a little bit less than half the cases of scrofula. Scrofula can be largely asymptomatic, maybe some slight tenderness. All right, true or false? GUTB is usually asymptomatic without fever or pain. This is true, but people can have pyuria and or hematuria on urinalyses in over 90% of cases. So that means that a normal UA is pretty good at leading you against GUTB. Um, GUTB has also been classically recognized as the cause of quote unquote sterile pyuria, i.e., it doesn't grow in typical cultures, but if you uh, grew it for TB, it would potentially grow positive. Okay, true or false? TB is the main cause of death in HIV infected persons worldwide. This is true. TB causes about a quarter of overall mortality in HIV, so it's a huge burden in HIV positive patients around the world. True or false? Extrapulmonary TB is seen in 15 to 20% of HIV infected people with TB co-infection. This is false. 50% of HIV patients with TB have extrapulmonary disease versus only 15 to 20% of non-HIV infected patients. So there's a high rate of extrapulmonary TB in people with HIV. True or false? About half of primary HIV infections result in an acute clinical syndrome. That's true. It's somewhere between 50 to 70% of HIV infections will experience some acute clinical syndrome about 3 to 6 weeks after the primary infection. Okay. True or false? An acute primary HIV infection can cause an FUO for over a month with negative HIV serologies. That's true. Symptoms usually persist for one to several weeks and gradually subside as an immune response to HIV develops and levels of plasma viremia decrease. So if you are considering primary HIV infection as a cause of FUO, it's important to repeat serologies several weeks after the person has had the FUO. True or false? Accelerated progression after HIV infection is thought to be more common in Africa. The answer is true. Um, and there could be several reasons behind it, including generally poor health, co-infections, and malnutrition. Okay, true or false? During the asymptomatic period of HIV infection, the average rate of CD4 T cell decline is about 150 per year in an untreated patient. That's false. It's much lower. The asymptomatic period of HIV infection, the average rate of decline is more like 50 per year in an untreated patient. It is recommended that initiation of ART, true or false? It is recommended that initiation of ART be delayed in ART naive patients with CD4 greater than 50 until 2 to 4 weeks following the initiation of treatment for TB. And the answer here is true. You are weighing the risk of TB iris from immune reconstitution versus the risk of other opportunistic infections from delaying ART. So 2 to 4 weeks is the range that is shown to be best. True or false? Infections with MAC, Mycobacterium avium complex, are rare in Africa. The answer is true, much more common in the US, among other places. True or false? Frequently newly diagnosed HIV patients presenting with cough, fever, and subtle interstitial infiltrates on chest X-ray can be treated with ART alone. This is true. The reason for this is because HIV can cause a non-infectious kind of subacute pneumonia, similar to LIP, lymphocytic interstitial pneumonia. And just by treating with ART, people can improve. All right, true or false? HIV infection incurs a modestly increased risk of coronary artery disease when CD4 count is less than 100. And this is false. It's probably happens at a higher CD4 count as well, and does give you a moderately increased risk. So regardless of how well controlled the HIV is, it does increase coronary artery disease risk. All right. The next question asks you, with sinusitis resistant to antibiotics, what treatable etiology needs to be considered in HIV patients? So HIV patients with sinusitis not responding to antibiotics, you need to think about mucormycosis. Next question, new onset heart failure and a worsening headache in HIV positive patient with a CD4 of 64 should be treated with what medication? The answer is Bactrim, and you are treating for toxoplasmosis, which can, cause encephalitis, obviously, and also can cause a dilated cardiomyopathy or myocarditis. Next question, which organism causes a polypoid mass involving the external auditory canal in HIV-infected patients? The answer here is PJP. Okay, next question, check one or more. Which of the following organisms can cause pulmonary and/or disseminated infection in patients with advanced HIV infection with symptoms of prolonged fever and cough greater than 4 weeks, chest x-ray with cavity lesions, nodules, and/or consolidation and positive blood cultures? So obviously this screams TB, but there's a differential here. And besides TB, Cryptococcus can also present similarly, Rhodococcus, equi, and then MAC if you are in the correct place. So not everything that seems to be TB necessarily is from the jump. All right. Next question. Pathogens causing watery diarrhea infect which part of the bowel? So watery diarrhea often is from proximal small intestine infection. The mechanism of inflammatory diarrhea includes which of the following? The options are enterotoxin, cytotoxin, and invasion. And the answer for inflammatory diarrhea are cytotoxin and invasion. Okay, this question asks you to indicate whether a certain pathogen gives you diarrhea through enterotoxin or through inflammatory. So I will read them off. Clostridium perfringens is enterotoxin. Bacillus cereus, enterotoxin. Salmonella is inflammatory. Aeromonas hydrophila can be either. Plesiomonas can be either. Staph tends to be enterotoxin. Vibrio cholera, enterotoxin. Giardia, enterotoxin. Cryptosporidia, enterotoxin. Entamoeba histolytica, inflammatory. E. coli can be either. And rotavirus, enterotoxin. Okay, next question. Which complications of acute infectious diarrhea can be seen post-diarrhea? And you can check as many as are possible. So all of the following can happen as a complication after acute infectious diarrhea. So one, people can have chronic diarrhea for over 4 weeks after the acute infection, and it's because they actually have a temporary lactase deficiency. Another complication, you can exacerbate known inflammatory bowel disease. People can also have a post-infectious IBS type process that happens in about 10% of travelers with traveler's diarrhea. They can also develop chronic diarrhea due to malabsorption, for instance, tropical or celiac sprue. And they can have severe anemia after the acute diarrhea. This would be in the case of HUS due to Shiga toxin from Shigella or E. coli. And they can have renal failure, same thing, HUS from Shiga toxin or from Shigella or E. coli. Okay, next question. Infective dose of pathogens varies widely. Low infective doses, 10 to 100 organisms, imply that person-to-person contact can transmit infection. That is true. Okay, true or false? Entamoeba and Giardia both have low infective doses. True, so that means they can be passed person to person. Okay, true or false? Invasive colitis and liver abscesses from amoeba are tenfold more common among women who prepare food for the family than among men. This is false. Entamoeba histolytica is tenfold more common among men than among women. And it's unclear why this is, but maybe partially due to disparity in complement-mediated killing and effects of testosterone on the secretion of interferon gamma. True or false, Entamoeba dispar looks identical to Entamoeba histolytica under the microscope, much more common than Entamoeba histolytica and is incapable of causing invasive infection. And so this is true. This means that a lot of our old clinical data on Entamoeba histolytica saying that there was super high rates of carriage and asymptomatic infection might have been because we were actually finding Entamoeba dispar. So this is still being worked out. True or false, patients receiving steroids are at high risk for severe strongyloides, but for reasons still to be fully deciphered, not Entamoeba histolytica infections. So that is false. Patients receiving steroids are at high risk for both severe strongy and Entamoeba histolytica infections. Okay. True or false, majority of patients with Entamoeba histolytica dysentery, so bloody diarrhea, have high spiking fevers mostly at night. And this is false. The majority of these people are actually afebrile. True or false, jaundice is rare with patients with Entamoeba histolytica hepatic abscess. That's true. The vast majority of people with hepatic abscesses from E. histolytica don't have jaundice. The few times when it is caused is because the cysts have gotten so big that they start to press on different structures, including the common bile duct. True or false, most older adults with Entamoeba histolytica hepatic abscess present with symptoms of weight loss and hepatomegaly lasting 6 months and are afebrile. The answer here is true. True or false, 10 to 15% with Entamoeba histolytica hepatic abscesses have an FUO without localizing symptom. And that is true. It's about 10 to 15%. Kind of give you an FUO picture. True or false, more than 90% of patients with E. histolytica hepatic abscess respond dramatically to Metro with decreases in both pain and fever within 72 hours. That's true. So this makes Entamoeba histolytica hepatic abscesses very easy to treat empirically and know whether or not you're treating the correct thing. Treatment after metronidazole should also include some type of luminal agent to eradicate cysts and prevent further transmission. Okay, true or false, more than 70% of people infected with schisto live in sub-Saharan Africa. That's true. This is the vast majority of the world's burden. True or false, dam building helps limit the prevalence of schistosoma mansoni, but not schistosoma hematobium. And that's actually false. Large-scale irrigation and hydroelectric power operations can create suitable habitats for host snails and thus increase the risk of schistosoma transmission. So dam building probably actually worsens the prevalence of schistosomiasis. All right, true or false, since water exposure continues over a lifetime, prevalence of symptomatic infection increases steadily with age, and this is actually false. Symptomatic infection probably peaks around puberty, and this is probably due to the fact that children have more frequent, prolonged, and extensive water contact than adults through activities like playing and swimming. Okay, true or false, acute schisto called Kayama fever with fever, cough, abdominal pain, headache, etc. occurs in visitors to endemic areas, not residents. And the answer to this is true because these people are like infection naive and don't have immune buildup or immunity to schistosomiasis. True or false, severe hepatosplenic schisto is due to obstruction of portal flow by the inflammatory response to adult worms in the liver. And this is false. What actually happens is you get a granulomatous inflammatory response to eggs laid in the portal veins and then are carried to or lodged in the preportal venules of the liver. Everything suggests that the eggs and not the actual adult worms induce the organ-specific morbidity caused by schistosome infections. So the difference here is eggs and not the adult worms. True or false, most patients infected with schisto have no symptoms. That's very true. True or false, hepatosplenic schisto leads to portal hypertension, but hepatic function usually remains normal. That's true because as we talked about, the inflammation and eventual fibrosis all happens in the pre-portal circulation. Okay. Um, the True or false, the prognosis of a variceal bleed due to schisto-induced portal hypertension is poor and recurrence is rare due to high mortality. That's false. Um, you have a better prognosis due to good hepatic function, INR, and the general status. And however, you do have relatively frequent recurrence. So as opposed to people with cirrhosis, your kind of clotting and etc. is intact. Okay. True or false? Renal failure is seen with schistosoma hematobium, but is rarely seen with Mantonite. False. Chronic renal failure due to complex deposition in glomeruli often uh, happens once people have portal hypertension. All right, true to false. Pulmonary hypertension doesn't occur in schisto in the absence of portal hypertension, and that's true. Okay, that's it. We blazed through 126 questions with the answers given and minimal explanation. The answers all come from the Harrison's textbook readings. If you still have questions after this on a specific question, feel free to email us or reach out and we can discuss it individually or in the group. Right. Thanks for your attention.